Thank you. Thank you. Wow, what a wonderful day of music and celebration and inspiration. I just feel like sitting back and enjoying it, but I have to talk, so I better earn my keep. It's great to be here. Congratulations to First Lady Catherine and the Governor, and thanks to their advocacy and leadership and the inspiration that they give us all around addiction treatment and addiction recovery. I speak at a lot of conferences, and I'm used to having the governor or their representative come in and they say a few greetings for a couple of minutes and then split. But here we have the governor and first lady leading this wonderful advocacy conference together. I live in, let's see, I'm not ready for that one yet. I live in Davis, California, which is a small university town about 15 minutes from Sacramento, about an hour and a half from San Francisco, about an hour from Napa Valley, about 3 hours from Lake Tahoe. So you get the picture about where it is. Sacramento, by the way, is the capital of California, not Los Angeles or Hollywood. Glad to be here. Just want to let you know that I was born and raised in Australia, but I'm Chinese, so I tell you that just in case you're worried about an Asian speaking like Crocodile Dundee. You know Crocodile Dundee? Yeah. Because I want you to listen to what I had to say today and not be thinking about, is that New Zealand or South Africa or United States? So g'day, mate. Australia's out of the way. Now let's get on with the topic. It's really great to be here to talk about Recovery Reinvented, but let's get some terms and agreement first. I really admire the work of Bill White. If you haven't read his work, he has it all on a website. His definition of recovery is this: recovery is the process through which severe alcohol and other drug problems, remember alcohol's a drug, so it's alcohol and other drug problems, are resolved in tandem with the development of physical, emotional, ontological, spirituality, life meaning, relational, and occupational health. In other words, recovery is a holistic process, the whole person. And the work of Tom McCullen, who really did treatment outcome studies for many years, I've always admired his work. He got together with a bunch of people at the Betty Ford Center, I think it was. And this was a segment of what they were talking about. The immediate goal of reducing alcohol and drug use is necessary, but rarely sufficient for the achievement for the longer-term goals of improved personal health, social functioning, and reduced threats to public health and safety. So when we're talking about recovery, we're talking about whole person recovery. It's not just not drinking and drugging. And the American Society of Addiction Medicine, organization of about 5,000 physicians and other associate members, if you'd like to become a member and not a physician, about 7 years revamped their definition of addiction. So ASAM, actually it's pronounced ASAM, not ASAM. Some people think it's a pain in the ASAM, because here in North Dakota you use the ASAM criteria, and we'll make reference to those in a little bit too. But ASAM, talks about addiction as a brain disease. You've seen pictures like this before. I think Jess is going to give you a bit more of a tutorial on this as well. But ASAM defined addiction as a primary chronic disease of brain reward, motivation, memory, and related circuitry. So that circuitry, when it gets dysfunctional, manifests itself in the disease of addiction. And we know the characteristic biological effects, the social effects, the psychological effects, the spiritual effects of addiction on all people. And when people are using certain drugs and certain addictive behaviors like gambling, they're manifesting the disease of addiction. Now, ASAM talks about addiction as the disease of addiction, not the addictions. Sometimes you'll see people talk about the addictions. It's the disease of addiction manifested in some people with alcohol, or as we heard Laurie talking about, alcohol and cocaine, or sometimes gambling. So just because you stop one drug, if you're not getting into recovery around the disease of addiction, that doesn't mean that you're in recovery just because you stop one drug. You see that, people switching and so forth. And so we're really talking about a biopsychosocial spiritual disorder, a brain disease that manifests in this holistic way. And I wasn't taught much about addiction. I went to medical school. I had my psychiatric specialty training first couple of years in Ohio State University, the third year in one of the Harvard Medical School programs in Boston. And when I got out of that very good training, I realized I didn't know much about addiction. I was assigned to an addiction treatment team on an inpatient psychiatric unit, not because of my exquisite knowledge about addiction treatment, but basically they couldn't get anybody to work on that team. So I had to get on-the-job training around addiction from addiction counselors and learn and unlearn some things about addiction that I was never really taught. Unfortunately, people aren't taught much about addiction, and I hear people say sometimes, I don't want to work with those addicts, those alcoholics. If you work in healthcare or in schools or in law enforcement or criminal justice or any setting, you're going to be working with addiction whether you like it or not. And as you know, addiction has physical, mental health, social, affects families, significant others, public safety, safety for children and families. And if we don't ask the questions to make the diagnosis, in the emergency room when that person gets fixed up for their broken leg from driving drunk, it's no good just fixing up the broken leg without saying, hey, maybe you have the disease of addiction. It's no good surgeons doing a successful appendectomy and then 3 days later the patient's in the DTs or in withdrawal because nobody took an alcohol history. It's no good mental health people just looking at the symptoms of a substance-induced disorder. See, is this really anxiety disorder, or is this somebody withdrawing from benzodiazepines or alcohol? Is this really major depression, or is this somebody who's crashing from cocaine or methamphetamine? Is this really bipolar disorder, or is this somebody using uppers and downers? I mean, there's so much bipolar disorder around now, you think it's in the water. Have you noticed that? I got bipolar disorder, I need medication. Well, who gave you that diagnosis? The doctor? Well, how long did they speak with you for? 10 minutes? Did they take a substance history? No. Did you tell them what you're using? No, but I got bipolar and I need medication. See, we've got to make sure that we're really assessing people, because addiction is a great mimicker of so many areas of health and in social sort of problems. See, if you only see addiction as the behaviors of addiction, then you're going to see somebody who breaks the law, who lies, who is immoral, who's a weak-willed person, and that puts them into the criminal justice system. So we have a counterproductive view about what addiction is, just seen as bad behavior, and then we want to punish them. I was supervising some personnel that work in a drug court, and they said, we just admitted somebody into our drug court who is a 23-year-old young man, 16 substance-related, drug-related charges. 16 drug-related charges, young man, 23. This was his first chance at getting treatment for addiction. Now, you would have hoped that criminal justice, law enforcement might have said after 8 drug-related charges, whoa, maybe this person has addiction. Maybe if we gave them a chance at treatment, not only would we help this person, but we would increase public safety, decrease legal recidivism and crime, and spend less money. It would be a win for everybody. In California, it costs about $75,000 to put somebody in prison for a year. I don't know what it is in North Dakota. Your real estate's a little cheaper than California. But the point is, when we don't understand addiction and we just see the complications of it, the manifestations of it, we waste money and we don't help public safety anyway. Because if just locking people up changed people, people would go to prison and say, well, I'm never coming back here again, I'm changing. Now, if you say it's a disease, are people still responsible for their behavior? Well, a counterproductive attitude about thinking about addiction as a disease is that, don't blame me, it was just my disease that got me into the bar drinking. My disease made me do it. No, you're not responsible for your disease, but you are responsible for your recovery. You have to take responsibility for identifying where and what are the triggers and the relapse situations to you. But even addiction treatment providers get this mixed up. They don't sort of get fully the balance between responsibility and the relapsing nature of a disease. How many of you have heard of people who go to treatment they have a flare-up of their addiction, they have a drink, and they're kicked out. How does that make sense? I'm depressed and I've got suicidality. Oh, you got suicidal? You're discharged. 3 times suicidal, you're definitely coming back here for 30 days. Or come back tomorrow when you're not suicidal. See, the problem with even addiction treatment providers, we don't understand what addiction is. So it's relapse, relapse, rethink, not relapse, relapse, kick out. And we have to begin to treat the disease of addiction. Thank you. Yes, we have to treat the disease of addiction the same way we treat flare-ups of any other disorder. You don't get kicked out because your blood pressure went up, because your blood sugar went up, because you got psychotic, because you had a panic attack, because you got suicidal. That doesn't mean that we don't take responsibility, but how do we use that flare-up to learn from that? And if the person's willing to change their treatment plan in a positive direction, we keep going. If the person doesn't want to change, they have a right to choose no further treatment, but they're taking themselves out of treatment. We're not kicking them out. So we have to understand, even in addiction treatment, what addiction is. Now, I've been chair of and chief editor of the ASAM criteria, which here in North Dakota you're using, and you can see up here, we don't have time to talk about it, but a continuum of care for chronic disease management of addiction. It's much more than just residential treatment. In fact, you might not like this, but we don't need more residential treatment beds. We need more of a continuum of services with community resources and housing. We need support for people to get back to work who have felons. We need community resources to help people in wet, damp, and dry housing, not just sober housing, where if you use, you get kicked out. We want to be able to expand out the community resources so that we can shift some of those resources from high-cost, high-intensity services to the broad continuum of care, to prevention, to early intervention, to treatment, to recovery. So when we start thinking about treatment as the gold standard of residential, especially in a fixed length of stay mentality, we're really cutting short the opportunity for giving people as much treatment as possible to get the best chance at outcomes. And only in addiction do we still kind of think of treatment as some fixed length of stay. You know, nobody says, how long is your schizophrenia program? It's a 6-week program. What about your bipolar disorder program? How long is that? That's a 3-week program. They're manic. They get through faster, you know. When are your graduations for your OCD program? Well, that's the first Friday of every month at 2:07 and 7 seconds. See, when do you graduate from diabetes? When do you graduate from hypertension? When do you graduate from schizophrenia, from depression? If we understand this as a chronic disease, we need to have the same resources and parity and the same mentality about stretching out the resources instead of thinking we send somebody off to rehab from which they graduate, and if Demi or Lindsay or Tiger goes to rehab, that somehow they have a makeover. That's not a chronic disease model. And the ASAM criteria is trying to get us to move away from healthcare packages just looking at thinking that if they detox somebody, then they've done with treatment. That's just the beginning of getting a person on the path to recovery. So we have to change our benefit packages. We need to change our treatment continuum of care. We need to spread out those resources so we can be good stewards of resources. Now, there are some disadvantages sometimes of the disease concept and the disease model and the disease understanding about addiction if you just think of it as a brain disorder. That's why I called this, it's not just a brain disorder. Because there's a lot of focus, understandably, right now with the opioid crisis on medication. But as this cartoon says, not only have the drug companies merged, apparently so have the pills. The focus on just medication, not taking away from medication, but this is more than a brain disease. This is a biopsychosocial disorder which George Engel introduced as a concept back in 1977, actually just when I was graduating from my psychiatric specialty training, so you can tell I'm quite old. And this is George Engel. He's old too. Now he's dead, but very old. But what he introduced about biopsychosocial was not that this was just a behavioral health. He was talking about in any disorder. So if you think about pain, You can have pain, but it also depends on your attitudes and beliefs about pain. I mean, physics-wise, you might have a dog bite or a love bite. They have the same pressure, but how you relate to it makes a difference to how you experience that pain. So your attitudes and beliefs pain, if you're under psychological distress, that pain's going to be worse. If you have illness behavior that says, I'm in pain, I've got to get a pill, and then if you live in a social environment where people are pushing pills and that we all think the solution to any problem is a medication. You know, if you look on TV, there's so many ads on medications that you can get. You rarely see anything about relaxation or mindfulness or meditation. We live in a society where pills and drugs are the solution. So in that context, then, if you think about addiction as a brain disease, but that manifests as a biopsychosocial disorder, we know that there are other causes besides just the dysfunctional circuitry of the brain. We know, for example, that in Scandinavian countries where people have been separated from their family at birth, raised in two different families, but are identical twins, so the same genetic material, there's still a higher rate of alcohol use disorder even though they grow up in different families. And so there's a genetic aspect to it. We know that there's a biological aspect to it. Sons of fathers with alcohol use disorder need more alcohol sometimes to get a good high than sons of parents who don't have addiction. So if you need more drug to get a good effect, increases your tolerance, increases the chance that you'll have addiction. We know there are psychological factors. So young women who have low self-esteem compared with their colleagues are set up to use certain mental disorders, borderline personality disorder, anxiety disorder, antisocial personality disorder. These things can push a person towards addiction. We know that there are social cultural reasons for addiction. Cultures where there's an absolute taboo against public drunkenness have lower rates of alcohol use disorder, where cultures that are ambivalent about public drunkenness, like our own, okay on Mardi Gras, New Year's Eve, St. Patrick's Day, not okay at other times. Cultures where there are drinking places like bars and taverns have higher rates of alcohol use disorder than cultures where drinking is more with family, religious rituals, with food. We know public health principles that the cheaper a drug is and the more available a drug is, the more the problem is. So what's your guess about our biggest drug problem in our society? It's not cocaine or methamphetamine, as bad as those things can be, but the legal drugs, alcohol, tobacco, and in California, marijuana. We'll see what that experiment's like. And the biggest killer is nicotine addiction. 480,000 Americans every year, 40,000 of those from secondhand smoke, and we're even talking about tertiary smoke, where you're sitting in a chair where people have been smoking and you get the effects. So not to take away from the opioid crisis, but the biggest killer is tobacco. And that's an area that we're not paying enough attention to. So we're talking about a biopsychosocial disorder, and who crosses that line into addiction depends on their own recipe of those biopsychosocial factors. So you might have a 65-year-old, social drinker all of his life, fined at his work, forced to retire by company policy at 65, fills that vacuum with drinking, shows up later on in life with addiction. 20-year-old, family history of addiction, whereas the 65-year-old had no family history of addiction. The 20-year-old, all of their role models, this is how you live, by drinking and drugging. 65-year-old had no role models that were pointing in that direction. The 20-year-old, no job skills other than drug dealing, no friends who don't use. The 65-year-old has many friends who don't use, has many work skills. Both have addiction, but quite different in terms of their presentation. So they need individualized treatment, where for the 65-year-old that might mean getting them hooked up with young entrepreneurs in the Junior Chamber of Commerce to do some consultation and get some self-esteem from working with that, whereas the 20-year-old doesn't need rehabilitation, he needs habilitation, right? He doesn't have any clue about how to have fun without drinking and drugging, whereas the 65-year-old still is in the golf club. So the point is, we have to start thinking about individualized treatment. Where does this all lead if we balance the brain disease with psychosocial, spiritual? Well, if you have a negative reaction towards medication and have a sort of philosophy that we don't use medication, you might want to learn about the brain disease and understand how medications really help people. If you have a negative reaction to 12-step programs, go to an open meeting and see what recovery looks like. And we've already heard 2 amazing stories about that today. If you think about the magic bullet is medication-assisted treatment, think again. In fact, I would invite you to change medication-assisted treatment to medication in addiction treatment. Sometimes I think that was a term that was developed to make 12-step and abstinence people feel comfortable. We're not going to mess up your treatment, but we're going to assist it with medication. But we don't say medication-assisted depression treatment, medication-assisted diabetes treatment. It's just medication in addiction treatment. MAT is not a philosophy. It's just a clinical tool. Some people need it for a short time. Some people need it for a lifetime. We have to rethink our attitudes about medication. If you're looking for a magic bullet because of this brain disease, there's not going to be a magic bullet. It's more complex than that. It's biopsychosocial. And so, is addiction a brain disease? Yes. Is it just a brain disease? No. If we want to get to full recovery, we need to reinvent how we educate people about addiction, both in the public, in medical schools, in healthcare. We need to reinvent how we design, deliver, and pay for a continuum of care. We need to reinvent how we move people through that continuum of care. We need to reinvent how we deal with flare-ups and not kick people out of treatment, hold them accountable to do treatment, but stick with them and hang in with them through the process of recovery. We need to reinvent how we look at prevention and early intervention and treatment. If we reinvent all these things, we will reinvent recovery. Thank you.